Thanks for joining us for a conversation today on Medicare and Annual Enrollment Period for 2026 and part of 2025. Today, we're going to discuss the changes that are impacting this year's Annual Enrollment Period and some things for you to keep in mind when we're going into 26. My name is Dan Lash. I'm a certified financial planner and a partner with VLP Financial Advisors. VLP is a financial planning and wealth management firm located in Vienna, Virginia, but we work with clients nationwide. Our goal is to be a trusted partner to the individuals and families and businesses we serve, and really to help them to determine how or what Live Greater is to them. In the last 25 years, we've grown our firm from 2 people. I was one of them, so I've been here a while. And today up to, I believe, 21 people. That includes 7 certified financial planners, 5 accredited investment fiduciaries, 2 chartered financial analysts, and a certified divorce financial analyst. Today, our advisors have a collective experience of looking at all of them over 100 years, and we're really proud to have been recognized in Washingtonian and Northern Virginia magazine as top advisors over the last decade, really. Our guest speaker today is Emily O'Halloran. Emily is an executive director of MP Group. They're an independent insurance agency that has grown to be a leader in the Medicare education and enrollment services. By focusing only on Medicare, MP Group agents have extensive knowledge and experience of benefits available in plans. Emily has helped hundreds, literally hundreds, and some of our clients of individuals as it relates to Medicare enrollment. She's guided clients in plan selection, benefit utilization, management of the Medicare impacts from life changes, understanding appealing Medicare, income-related charges, and anything else that helps her clients as it relates to Medicare. She was a regular speaker on Medicare education topics in our community with financial advisors in the area, in retirement communities, and much, much more. So, Emily, thank you very much for joining us today. Really appreciate it.
Thank you so much for having me.
Sure. So I think we get started with, I think you have some slides and some basic overtones of what's going on in Medicare that you want to discuss. Obviously, we can't discuss everything about Medicare because there's just too much to discuss in maybe 30 minutes or so that we'll be talking today. But wanted to hit on some points that you think are things that people really need to know that maybe they just can't easily go to Medicare.gov and find out, or just to give them some updates of what's happening, especially with all that's going on with the conversations around healthcare today that don't all necessarily apply to Medicare, but all you hear is healthcare, and immediately if you're on Medicare, you just go, well, that's got to affect me, when it doesn't necessarily do that. Take it away.
Okay, absolutely. And that is a great place to start, which is understanding the relationships between all of the different types of healthcare provided by the federal government, and couldn't be a hotter topic than right now. So that's what I think we should start with, is just really thinking about how the recent legislation may have impacts on Medicare and when those impacts will occur. And then we'll talk about the legislation that in our industry we really see as the driver for what's going on in Medicare at the moment. So, of course, as you referenced, this is a hot topic with the government shutdown. And of course, with the One Big Beautiful Bill legislation from July, there's been a lot of discussion. The average consumer, I think, conflates Medicare and Medicaid. But then, of course, once someone is Medicare eligible, they really start to understand what Medicare is. And if you're a Medicaid consumer, then you know Medicaid. But these are different programs that have some similar stakeholders and some commonalities. Now, with the One Big Beautiful Bill Act, there were some elements that are scheduled to impact Medicare currently and in the years ahead, but those are minor compared to how this legislation is really intended to impact the Medicaid and ACA side of the federal healthcare system. So the Medicare pieces are a couple of items. One that some folks who are here today or here watching and listening may have read about. One is something called the WISER model. This is a prior authorization demonstration project, and it's pretty interesting to read about. Those of us who love the way original Medicare works and how few instances of prior authorization there are in original Medicare may be concerned about this model that is designed to bring perhaps, depending on how this works, some prior authorization into original Medicare using AI. So the WISER model stands for Wasteful and Inappropriate Services Reduction. And the concept is to see how we can utilize AI in determining wasteful spending in original Medicare. Now, there's some opposition to this politically, especially as we take a look at the Medicare Advantage side of Medicare, which for years many have argued has had too much of a burden of prior authorization. So that's a hot topic. There is nothing at the moment that is impacting very many Medicare members at all. So it's something to be watching and reading about over the next couple of years to see where this program goes. Other pieces of the OBBB are focused on freezing increases to Medicare physician reimbursement. This is important because we do want to see healthcare providers receive compensation adequate and competitive to commercial insurance so that they continue to participate with Medicare. But that said, there is an argument to be made for containing spending and making adjustments to these payments in a slower fashion than has been scheduled. So these are pieces of this recent legislation that we're going to be hearing about a lot more in the next couple of years, but they are not having an immediate impact this month, this fall, on Medicare members who are currently enrolled. Again, these are things to watch or read about, listen for news on these topics. They could be bigger issues down the road, but right now they're not impacting current Medicare members. So again, with this particular legislation, the focus was really on cost containment in the Medicaid and ACA marketplace coverage. And this is being addressed through all sorts of things that have been all over the news. Of course, that's tightening of criteria for eligibility for all of these programs, whether that's in terms of citizenship status, assets and income requirements. That's something that's been a really overlooked topic in Medicaid eligibility. During the pandemic, many people became eligible for Medicaid just without even applying. This was something that occurred during the emergency use of these funds. And what happened was that people were eligible without their assets being taken into consideration, which, as I'm sure everyone can imagine, can really be askew. So it's quite possible to have income on paper that if it's just one factor that the federal government is considering, makes you look eligible for this federal assistance through Medicaid, but then when assets are taken into consideration, the whole picture changes. So if you do that over the course of millions of people throughout the country, we have, a lot of spending that's, being clawed back at this time through this big controversy over Medicaid spending eligibility specifically and the ACA subsidies. So again, that the citizenship issues, the issues over going back to the way we used to do things, which is considering the whole person for Medicaid eligibility, not just one number, not just income, but what's the big picture look like, their assets and their living situation, all of those other pieces to the puzzle. And then also, I'm sure everyone has heard or read about the argument surrounding work requirements for Medicaid assistance. So all of these elements are a part of this legislation, and the goal is to eliminate fraud, waste, and abuse in federal healthcare spending. which is important. I think the argument is not that we need to eliminate fraud, waste, and abuse, but how it's done. And so that's really a big piece of why we're dealing with this shutdown right now. Now, as of yesterday, it sounds like we have a bill passed in the Senate to fund the government through the end of January, I believe. And it is including a promise to vote on ACA subsidies. And this is really important because this is something that we're going to have to address to get this overall federal healthcare spending under control. This is important because we're talking about the same participants and stakeholders across all of these programs. Medicare itself is the largest form of health insurance in the country. So we have health insurance companies and pharmaceutical companies, and we have, of course, the healthcare providers themselves, the doctors, the pharmacies, the hospitals, the health systems. All of them are impacted by the same large federal programs. And so a hit in one is inevitably going to have a ripple effect in those other federal healthcare markets. So, as a potential future consumer of Medicare myself, each of us, we do want to watch what's going on in Medicaid spending and in this argument really over how ACA subsidies are determined and how they're administered. It's a really important topic for getting our arms around all of that federal healthcare spending as a whole. And it has to be done really carefully because, again, we're talking about the same health insurance companies and all of those other entities. Decisions we make in one area will impact how they do business in other federal healthcare markets. So, really, really hot topic and something to be watching. But at the moment, these are not the things that are increasing costs for Medicare members. They're not the causes of the exit of plans from markets, which many of your clients may have either seen themselves or they may have friends and family members who are experiencing some of those current issues of upheaval in the Medicare market. So we can talk about which legislation is impacting today, but did you want to address anything else on this topic or have any other questions about anything that I mentioned here
No,
regarding?
I think most of the things that we're seeing around healthcare are more, as you mentioned, more applicable to Medicaid and ACA.
Mhm.
And a lot of people, when we talk about Medicare, they just say Medicaid by accident, and I say, well, those are two different things. Medicaid is meant for people who don't have really hardly any money or assets, or a disabled child, or who, things like that. Medicare is specifically meant for those people 65 and older in the United States. And obviously the ACA is meant for, people who can't necessarily get health care through their employer, things like that, and they don't want to go without health insurance. Um, so no, that we could do a whole nother conversation on that.
We
Um,
could.
so I think we take a look at what's really affecting Medicare. What can people see down the road? Um, the problem is you don't want to look too far down the road because legislation can change.
That's right.
Um, and I think most people were worried about, well, what's 2026 going to look like potentially, because we don't absolutely know. But what might we be seeing in 2026 that may affect, an individual who's listening, watching's, their own personal Medicare. See, I did it.
No, you're absolutely right, Dan. The um, the 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 thing that we want to be careful about is that it is true that this, these legislative changes can be adjusted fairly rapidly in some cases. But as I'm about to share, some of those adjustments or let's say new legislation that does indeed take effect and hold, can have long-lasting impacts. So we'll talk about that.
Great.
Before leaving this, I just would encourage everyone to read and follow this topic as much as possible. Of course, we all should always consider our sources and the bias coming from each of those sources. And then one other thing to really consider and understand about the difference between Medicare and Medicaid when you're reading the news is that Medicare, for better or for worse, is a federal program with minimal state involvement, let's say. There's some states that have ways where they impact how Medicare insurance is offered and a few little touches. But Medicaid is a state federal partnership. And what that means is that you see something different in every state in the nation. And there's good and bad to that. So the good is that it's serving those, constituents locally. You get what you voted for, and they're getting what they voted for around the country in every state. But the tougher part is how do we change this program that is partially federal when we have 50 states and more and territories that are administering it differently everywhere. So it's pretty chaotic for that reason. So it's the blessing and the curse of federalism, and we'll just leave it at that and hope that we get some forward movement in addressing it and facing it. Of course, we really do have to face spending as a nation. This is a really huge part of it. So let's fingers crossed for cooler heads to prevail and wiser minds to be working on this problem. It's a big one. All right, so what is the legislation that's truly impacting Medicare right now? So that's going to be the Inflation Reduction Act of 2022. And there are some pieces of this legislation that were incredibly popular and arguably, did begin to address things that needed to be addressed. But what I'm going to explain here today is how some of the elements of this legislation may have been too aggressive and how we're now feeling that in all of the Medicare plans throughout the nation, the availability and the cost of those plans and the pressures that those private insurance companies who are the Medicare plan providers are feeling as a result of these pieces or the elements of this particular legislation. So to explain this, we have to talk about what Medicare Part D or prescription drug coverage used to look like, which is from when it started in 2006, there were always these different stages of coverage. Now, if I happen to have really good employer coverage through my spouse, so with that, we do not have a deductible on our prescription drug coverage, and we have, a very, very minimum copay, and our costs are super limited. So there's, to be honest, a lot of room for abuse in that type of coverage arrangement. If I wanted to keep a certain inhaler in my purse and in my car and upstairs and downstairs, I just keep refilling it. I keep refilling it and I put it where I want it. Well, I might not use it. It might expire. If it's the same copay to me each time, it doesn't really hurt me to do that. When consumers transition over to Medicare, so many that we've worked with over the years have had such a rude awakening coming from fantastic group insurance where they've been able to fill medications that they had no idea were actually really costly because to them, they weren't. They had low copays or no copay. There was no deductible to contend with. And people kind of get lulled into the sense of, well, that's not what it should cost. You actually had really fantastic insurance. But from the time that Medicare Part D began in 2006, it was structured so that there would be these coverage stages where the Medicare member who had this coverage had some skin in the game at each point along the way. There was most often a deductible, a pretty substantial deductible. When I say most often, some plans would have a lower deductible because they had a higher premium. Some plans would not apply the deductible to low tier medications. So not everyone experienced the deductible, but in my example, let's say I use an inhaler and I just want to keep one everywhere I go, or an EpiPen or whatever it is. Oh, I would notice that deductible. And so I would really think twice. Am I filling this as needed? And of course, the insurance companies are watching that utilization as well. And then the last of the coverage stages was something called catastrophic coverage. And so for many years, again, going back through 2006, Medicare plan members, members of any type of Part D coverage, so this is either a standalone prescription drug coverage, which most of our listeners here today who are on Medicare would probably have. That's the type of prescription drug coverage that you have when you have original Medicare and a Medicare supplement. But Part D is also built into Medicare Advantage plans. So most individuals who are on any type of Medicare have Part D. And for all of the years that Part D has existed, there's been a catastrophic coverage stage. Again, the idea is as a consumer, you're going to be sure to need that medication because if you're filling it on a whim or without true medical necessity, it's going to cost a lot. And so, as a prescription would get filled throughout the course of the year, when there was a certain amount of spending, then that consumer would go into catastrophic coverage. For all of these years, that coverage had a 5% coinsurance. So 5% doesn't sound like a lot until you recognize that there are now medications that have retail costs of between $300,000 and $400,000 a year. So 5% is really, really scary. And even before getting to catastrophic coverage, I'll just mention here the coverage gap. I don't know how many people remember for years there would be commercials on TV, during whatever political season we'd be in, talking about eliminating the coverage gap or the donut hole. And eventually that was minimized. And then with the Inflation Reduction Act, it was completely eliminated. So it's gone. It's been gone for a year. But the question is, how much of a job was it doing keeping drug spending down? Because the Medicare member was incentivized to fill what was medically necessary and pay their part through each of these stages. So, in a way, these pieces feel like good news when you're that consumer who has a really, really expensive medication and who's had it and who will continue to have it. You think elimination of the coverage gap or the donut hole, what's wrong with that? Elimination of my portion of the catastrophic coverage on my very expensive medication, what could be wrong with that? Well, the problem is that this has all occurred so quickly that those massive costs for very expensive medications are being passed on to everyone else on Medicare Part D plans in a couple of ways. So in 2025, that catastrophic coverage I mentioned, again, going back to 5%. Now, 5%, if I reach that coverage limit at some point in, or that catastrophic coverage stage, let's say I reach it in August, I'm spending thousands of dollars a month to make it through December 31st. And I can tell you that going back to years like 2022 and 2023, I personally had clients who I assisted with selecting coverage, and we would spend hours looking for every possibility. And the best that we could do would be to get their spending down in the range of $10,000 to $20,000. And that was with the best coverage arrangement that could be found. That's how bad that 5% was for certain people, a small group of people, but it was really unpalatable. The highest I ever personally saw was $33,000 in out-of-pocket spending for the year for someone who had coverage. That's how that 5% could really add up. So the 5% gets eliminated as of 2025. This is all part of the Inflation Reduction Act. The donut hole or the catastrophic coverage is eliminated. And again, also in 2025, for the first time ever, now we have a maximum out of pocket on prescription drugs of $2,100. This means that, let's talk about the same consumer. We'll use an example of several people I had whose spending was going to be in the past under the old model around $12,000 out of pocket. So $12,000, when we eliminated that coverage gap, their spending got down to a ballpark of about $3,400 for the year. Humongous improvement, fantastic. Most people would be really excited about that. And that's not to say that $3,400 for the year in out-of-pocket spending isn't a hardship for many people. It certainly is. But again, we're talking about a small percentage of people. The next step in 2025 was to take that number to 2,100 by completely eliminating the 5% in catastrophic coverage. So now we have this big shift where the Medicare prescription drug plans are responsible for the cost of these medications starting at a much lower number, which is occurring much earlier in the year. And we're going from a smaller percentage of people who will actually hit this catastrophic limit to a higher percentage. And I can give you some more information on that. So by taking the catastrophic limit, and this is again the out-of-pocket maximum that a Medicare plan member will spend on covered medications. And I should make sure I clarify that because there are a lot of people who will spend on medications that their plan doesn't cover, whether they're using a medication off label or it's something that Medicare just doesn't cover as medically necessary, or whether they've decided to get their medication for a lower cost through an organization that doesn't take insurance or from another country. There are all kinds of ways that people will get their prescriptions, but for the prescriptions that they run through their plan, as of 2025, that out-of-pocket spending has been hard capped at $2,100. Now, the impact of this is that in 2024, 3% of Medicare members would go into catastrophic coverage. It's anticipated that at the end of 2025, we will have 20% of all Medicare members reaching catastrophic coverage. So it's a really big shift in how many people will reach this point, now $2,100 of spending, that will then require that actual plan, their Medicare Part D plan, to cover the majority of the cost of the medication for the rest of the year. On top of that, one more thing happened with the Inflation Reduction Act that further pushed the responsibility of paying for prescriptions onto the insurance companies. And that is that the way prescriptions are covered in the catastrophic coverage stage used to be partially borne by the insurance companies. That was at a rate of about 15 to 20%. And Medicare itself was paying about 80% of the cost of the medications once that Medicare member reached that catastrophic coverage limit. And that could happen in January. So we're talking about, all of February through December. Sometimes it would happen in August or later. But whatever is being covered, that cost was borne more by Medicare or the federal government prior to the Inflation Reduction Act. But the Inflation Reduction Act, in an effort to lower that spending, that catastrophic spending, which has been one of the biggest issues in Medicare, the Inflation Reduction Act took the percentage that Medicare pays from 80 down to 20%. And the insurance companies went from paying 15 to 20% to now 60%. And if you'll notice, there's 20% missing in covering those drug costs and catastrophic coverage. And that is from the manufacturers. So those pharmaceutical companies through discounts are covering that 20-ish percent. So all at one time, we've taken the threshold for catastrophic way down. In 2 years' time, we've gone from unlimited to 3,400 to 2,100. And at catastrophic coverage, now the plan member is not paying and the plan provider is with Medicare's help. But we also switched roles. Now Medicare is not picking up 80% with the plan picking up 20%. Now the plan is picking up 60% instead of their former 20%. So these two factors at one time have caused major increases in costs to the insurance companies that offer Medicare prescription drug coverage. And it's been a shock to the system. So, as a result of all of this, really going into place, and we've kind of just been watching it in slow motion, thinking, is this really happening? This is really happening. Is this really going to do what we thought it was going to do? As a matter of fact, here it is. So, we have seen plans themselves eliminated. We have about half as many plans as we did going into 2026 than we did in 2025, where we had half as many plans as we did in 2024. So we're seeing this reduction each year since the Inflation Reduction Act went into place. And then we are seeing premiums for prescription drug coverage in many cases double. Now, certain plans have designed themselves to accommodate these changes, and they do that by providing coverage for medications that are most likely not going to take that member into catastrophic coverage. And that's territory that gets a little bit more complicated, but there are plan providers out there that are set up to cover very expensive medications, and they're taking big hits. They're taking big hits on costs. So the piece that is missing in planning for this implementation, which we argue has been too fast. This has been too much, too soon. And as a result, we're seeing competition being whittled away. And in some cases, just completely macheted away, let's say. So we're talking about less competition, which is driving those premiums up and meaning that there are fewer choices for the consumer as we look at all of this.
In general, prior to the Inflation Reduction Act, what we were seeing Part D premiums look like? Obviously, it's a big, broad range. Because you said doubled from what numbers in general? Again, it's a generality. We can't say, oh, everybody was paying X, because it's probably A through Z what people were paying. But for somebody listening who's not quite on Medicare yet, obviously people who are on Medicare, they know what they're paying, and they go, well, if it's going to double, if I was paying $100 a month, I know it's going to $200 a month. I'm just making up numbers. But have you seen what those numbers look like, and to give people perspective?
Sure. So just taking a look at this DC metro area, one of the most popular plans, and I say popular by sheer volume of members enrolled because of its price point in about 2021 and 2022. It was very low in the DC, Maryland, Virginia area. That monthly premium was in the ballpark of about $10 a month. It went down actually the next year. And so, of course, when that happens, at that point, it was about $5. And so it had a big surge in enrollment. And the trick with Medicare coverage, specifically prescription drug coverage, and this is, to some extent true on the Part C Medicare Advantage plans, really everything that I'm talking about here, again, is impacting the Advantage plans as much as it is the Part D plans, because the Advantage plans, a big piece of them is Part D coverage. So just to use the example of this plan I'm referring to, they had a big surge in enrollment because it was just priced so favorably, and it was also really suitable for people who took a look at it, for people who took just, commonplace medications. So big surge in enrollment. It stayed at that price point, approximately, $5, give or take, depending on the state in the region, and throughout the country. It was about that throughout most of the country. And then it started to creep up. In many cases, that particular plan, which I won't name, but that particular plan went up to about $50 a month. So that's, a 10x change in some areas, which was really shocking for many people, as it should be. It should be shocking to everyone. And so people who were paying attention looked into it. At that time, we were able to assist clients with, selecting something new that suited their needs. And then going into 2026, this particular plan in many areas, again, right around the DC metro area in particular, is going to be about $80 a month. So it's just been, you can't even call that creep. It's just been this wild swing in that premium amount. Now, the problem, Dan, is that while the premium has changed, what that plan has covered has not changed as significantly. So, unfortunately, our system favors the knowledgeable consumer. It favors the active participant, the person who's paying attention and taking a look at what's available from year to year. Because that plan, just like any other plan that's doing something similar, and many others have had similar increases over a, 3 to 5 year span, if you don't select new coverage, you're automatically re-enrolled in the coverage you have. A lot of
Sure.
people will miss that notice,
But
and
didn't
people
you
get
see that in
busy.
years past when people would, again, this comes back to the people who were actually paying attention to their
Yeah.
coverage. Um, didn't you see people shopping around and saying, "Hey, well, the medications I'm on today are different than they were a year ago, so I probably need to look at a different program." Um, so, I mean, I've been doing this for, I don't know, being a financial planner for 25 plus years. Every the conversation was always around, hey, your medications are going to change as you get older, and depending on the Advantage plan or Part D plan that you have, you really need to look at your various programs. Obviously, it sounds like there's less to look at today because there's less, insurance providers. Um, but it sounds like that's still the case, that people still need to be cognizant of that and consider looking around if their medications have changed, and in this case, you're maybe not, even if they haven't changed, you might want to just look, because now that it's just all about price and not necessarily coverage. Is that relatively accurate?
It is. It's absolutely accurate. And I think that maybe the way to clarify the difference between how things were before the Inflation Reduction Act and now is that prior to all of these changes I've described, the risk was in having a plan that was not as low as it could have been for maybe your costly medications. So let's say you used Eliquis and Humira and some other, expensive medication, which those are very ubiquitous and very expensive. So a lot of people would fall into that category. And we could see where we could maybe find coverage where total out of pocket for the year was, let's say, $1,200 on one plan. And on another plan, that person is going to hit that $3,400 maximum spending that was the potential.
Yeah.
So that was the risk, that they were going to way overspend for the same medications because they were a user of expensive medications. Now, with the maximum out of pocket being so much lower and these pharmaceutical discounts being applied, the consumer, in any consumer that takes one very expensive name brand medication is going to be likely to hit this catastrophic. And so they have less risk, but now the consumer who takes two or three generics, but who hasn't been paying attention in their plan, is at risk of spending $1,800 on premiums when their medications cost pennies. So the risk has been shifted from people who were users of very high cost medications, and that's who we had the most impact on, I think, in the past, helping them, save usually, a couple $1,000s a year by dialing in their selection. Now they're taken care of with this new, much lower cap and all of these discounts that are applied to their spending. Now it's making sure that the consumer who doesn't need a premium of 50, 90, $110 a month isn't just sort of unknowingly enrolled in that plan, getting nothing for that premium. So
Sure.
it's just a shift in how to look at it. But again, either way, it's super important to be looking at how you're covered and are you getting what you're paying for out of your monthly premium from these plans? Because the drivers of the premiums are not typical. You know, you have a lot of consumers who are used to the way their auto insurance works, and I'll take a higher deductible and get my premium down. You can have a really, really high premium and still have the maximum deductible in Part D.
Yeah.
It's a totally different incentive structure for these plan providers. And so the consumer has to be more careful than ever, unfortunately.
Yeah, I mean, it's unfortunate. We see it all the time in our business, the unintended consequences of government regulation.
That's right.
If you were the person who couldn't afford any of your insurance and, you were going without things because of the catastrophic situation, meaning you may have died sooner, um, those people were going, this is better for me. But as you mentioned, it's not, the vast majority of people. But it's hard to switch things, just say, hey, let's just help this one little small group. And how do you compartmentalize that, right? It's kind of like having taxes at different rates based on different zip codes because I make more money in this general area than somebody who lives in Idaho or some remote place of the country. So that I totally get that. But it sounds like what you're saying is costs are going up. Um, the amount of options that you have available to you to choose from are going down. And until the insurance companies have more experience, because usually the underwriting is the thing that affects um, their out-of-pocket or affects their premiums, right? Their experiences with the amount of claims that they're getting tend to affect what they're charging. But in general, you don't tend to see older people getting healthier over time. Unfortunately, we all don't get healthier after age 60. Well, we might have a situation and then we get better, but we're
Better.
not progressively getting healthier as we get older. It tends to go the other direction. And, it sounds like the person has to really spend some time and effort to, look at the things that are available to them, even though they're not as available as they once were, and try to make the best of the situation, unfortunately. Is that relatively accurate?
That's right. And understanding who has been impacted by this legislation is important, that it is impacting everyone. I think it was well intended to help that, again, that was 3% who were hitting catastrophic coverage and really being hurt pretty badly in some cases with those unlimited costs. So it was well intended to assist them. Now we're seeing, likely 20% of people hitting that threshold. And I think we can take, ideally, the idea would be to take another look at this mathematically and say, where do we need to be between 3% and 20% to provide relief to those who need it without hurting this industry, which will hurt everyone. It already has, this
Sure.
lack of competition going into 2026 is one of the impacts. And all of this is happening again while we're seeing these other things taking place. We're seeing healthcare inflation as higher than other forms of inflation, which is always true and certainly very true right now. Many people point to lagging impacts from the pandemic. So people who have had healthcare events that they haven't been able to fully resolve since the pandemic has been an impact, especially in the Medicare aged population. So there's much higher healthcare utilization over the last few years, and that's impacting increasing Medicare supplement premiums, which is a topic that some clients may have noticed or brought to your attention. They certainly are concerned about it and bringing that concern to us as well. So that's one of the things that is just going on simultaneously with all of this change in Part D, whereas we used to see, annual increases on a Medicare supplement premium. We were happy if it was under 10% and really happy if it was closer to 5%. That seemed suitable given the members' increasing age, which is increasing risk, right? So it's not just inflation, it's risk too. But now, in the last year and a half to 2 years, we're seeing increases in Medicare supplement premiums across the country, across even the most competitive carriers. We're seeing 15 to 22% even. And it's a little bit, not a little bit, it's a lot eye-opening for all of us involved in the Medicare market. So we want to see healthcare spending go down, and that again is all of these markets we're talking about, whether it's Medicaid and ACA or Medicare, it's utilization that will come back to us in premiums being paid in the years ahead. And there's, more high cost prescription drugs available than ever. We all see those commercials on TV. If you see it on TV, unless you have great insurance, be ready for the price tag on it. That's something that they just seem to get more expensive all the time. So any measures that can be done to negotiate better costs on those will be fantastic. That's a piece that sometimes people will ask about with the Inflation Reduction Act. That was pretty popular. The ability to negotiate drug cost prior to the Inflation Reduction Act, Medicare was prohibited from that process of negotiating drug costs. And now we have 10 medications per year, increasing to 20 that are able to be negotiated by Medicare. Sounds great. It definitely is a step in the right direction, but the impact has been less than 1% of total Medicare spending. So it's a drop in the bucket. Great concept. We need to do more of it, and we need to find more ways to bring down the cost of pharmaceuticals and on all types of health insurance in this country.
I think what you're saying is it's probably even more important than ever from anybody who's getting ready to go on to Medicare, or even if they're currently on Medicare, which is the difficult part because sometimes they're significantly older and have a hard time understanding some of the things. You might be 85 years old and trying to navigate all the stuff that comes along with, figuring out what insurance to get with Medicare. I work with plenty of older people, and they want things to be less complex in their life than more complex. And
Absolutely.
I think what this leads to is, job security for you, in the sense that you should be getting more phone calls. I think people need to do their due diligence. And in some instances, they have to, and I'm sure you probably see this where some much older people on Medicare are, employing, not necessarily employing, but bringing their adult children in to help them understand it and maybe even make the decision to a certain degree for them, because it's hard to understand everything. That's why you have a job. I mean, it's similar to my job. If financial planning was so easy, everybody would just do it themselves. It's just really complex because of all the regulation and all the rules that they create, and um, you just want to make sure you're making the right decision in an ever-changing landscape.
Unfortunately, that is one of the biggest impacts, at least to us and to our current clients and prospective clients, from all of these cost-cutting measures. So, as the plans have been really, just contracting and regrouping to determine whether or not they can continue to do business with Medicare, the first thing to go was contracts with independent agents like me and like all of MP Group. So this impacts Part D standalone prescription drug coverage, where we can no longer, as of just a couple of weeks ago, we can no longer meet with clients to represent Part D drug coverage and to assist them with selection and enrollment in those plans, which is a drastic difference from what we've always done. We have clients we've had for years who are used to having an annual meeting with us where we plug in their prescriptions and we say, this is the plan for you. Any questions? We answer those questions and then we enroll them. And we cannot do any of those things as of right now. Again, it's cost cutting. We're not paying anyone to offer this coverage. If you want this coverage, you have to come find it. So we're doing the best we can to adapt to that by trying to support our current clients over email with just what minimal compliant information we can provide, and just, pointing them in the direction of again, compliantly what they can select and where they can select it
Yeah.
for themselves. Same is true with the Medicare Advantage plans. These are the same insurance companies, and it's really not profitable right now in much of the Medicare Advantage market. And part of what goes is us. So having that, like I have here, direct and independent assistance on selecting this coverage is, we hope, temporarily eliminated. But as of right now, we cannot directly advise on selection of Part D, and it's very limited what we can do with Medicare Advantage. We're still working with Medicare supplement coverage, and we're still working with new clients who are transitioning over to Medicare, which is, in many ways, the hardest time is getting used to, how do I get into Medicare? How do I make my selections, and how do I start? And that we can do that education and that enrollment process in Medicare supplement, and explain everything, and get clients on their way. There's a big difference in the Medicare population. There are tons of people who are on Medicare who are 65 and on up, who are very young and who've just come from working, and who are more technologically savvy than I am, and who can do all of these things. But then there's a gap, and a huge portion of the Medicare population that is not as equipped for all of this complexity. And
Yeah.
so I really do hope that we're able to return to our full level of assistance that we've always been able to provide, and that in the meantime, that more younger generations get involved with supporting family members who need help with following all of this, and making sure that their loved ones are covered well.
Yeah, that's great. I really appreciate it. We appreciate your time and talking through these things. I know we didn't get into a lot of detail, but getting into detail in a conversation like this, is different for every client, right? And so we want to give people a broad idea of things that they need to be thinking about and considering. Um, and the biggest point here is do due diligence. Spend some time looking at your particular situation and trying to figure out, and that's going to take time and effort. Contact someone like Emily at MP Group, and hopefully they can help you with your particular situation. If you're having problems, doing it on your own. So,